Hello, everyone, and Good Friday. And indeed, it is Good Friday. So great to get to be with you all on April 18, 2025. SADS Live Nation, how are you? I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic, director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and the Sudden Death Genomics Laboratory. I'm here on behalf of our SADS Foundation and give you greetings from our CEO, Alice Laura. So this is SADS Live 167, and I missed you. I haven't been here the last couple times, or the last time, and I've missed your questions. I'm excited to see what you bring my way as we come to one of my most favorite weekends of the year, Easter weekend. And so to all of you, shout out. And I have for Julie, if she's there, this is for you, and thinking and praying for your precious grandson. I'll show you another hat that I got this week. Check this one out. I got this from one of my favorite patients. Well, all of my patients are favorite, but this is from Nolan, 18 years old, and he was declared the homecoming king. And he said if he would ever win something, he would give me his crown. So that's from Nolan. And then he just hit a triple on his first at bat for his varsity senior year in baseball earlier this week. So that's that. And now is our time together to take your questions before we get in there. And Julie is online. So all of you, wherever you're at right now, whether you're in Florida, which I think she might be, or wherever Jessica is, which is the first in the queue with a question, and I will take yours first, Jessica, or in the evening on Good Friday in Europe or down under, wherever you are. It's great to have you join us. Whatever your condition is, in terms of which is your SADS condition. Are you long QT syndrome, CPVT, Brugada, short QT syndrome? We don't mention that very much, but I just saw another one. We don't see them very often earlier this week, and so delighted to meet that precious family. Or arrhythmogenic cardiomyopathy, ACM or ARVC. We hope you find SADS a good home for you, a home that gives you great information on www.sads.org or www.stopsads.org, that when you go there, you get your needs met, that you feel empowered and informed, you feel confident that we are on our way to living and thriving as fully as we can. We are working hard for your diseases and to meet your needs, whether they're physical, emotional, and the like. And the team of Alice, Laura, our CEO, Marcia, Aaron, all of them are just amazing individuals and incredibly committed to you and your families as our nonprofit advocacy organization. So join us, participate with us. Let us know if your needs are not being met so we can do better. And join us financially. Go to that website, go to the top right corner, Stop SADS, or that red button, Donate Now, and join us in a philanthropic or a donation gesture, or link us to somebody with wealth so that they could do that. And we thank you in advance. So here we go. Questions are yours. I take them in order. I never skip them. And so I go back to the top. As Erin will say, if she didn't already, keep them. Oh, she did. Try to keep them short and easy to read. Thank you, Erin. Jessica, has any government funding changes impacted any of the SADS conditions clinical trials? Great question. A lot of noise out there. The short answer is not at all. My program is full speed ahead. The clinical trials that are in motion from the various industry-sponsored trials, whether it's the upcoming Thrive Therapeutics trial for LQT-1213, full speed ahead. The potentially upcoming gene therapy trial for patients with CPVT, sponsored by Solid Biosciences, it's full speed ahead. The current gene therapy trial from Tenaya, Lexeo, and Rocket, yes, those three for PKP2 ARVC, full speed ahead. So try to block out noise. That's what I do, and focus on the reality. From my vantage point, nothing has slowed down in terms of the progress from a governmental or an NIH perspective. Scrolling down, Laura watched a video posted in January, and you talked briefly about a new CPVT trial this summer. Do you know if it's for adults only or if teens may be able to participate? Great question, Laura. I'll give you the update as I know it. Now, I may not be aware of every single trial, and if I forget one or don't name it, I am not trying to leave anything out by design. So there are some updates. The CPVT drug trial from the company Armgo Pharma has been stopped, and it is no longer in motion. They have ceased that compound's development for the purpose of CPVT for now. But there is the CPVT trial from Cardurian, and that is still enrolling patients. My understanding, and I could be corrected, and I'll look if one of the members of the SADS teams know, it is still for 18 and older. Almost all of the first trials will always be 18 and under, and that's by government FDA mandate for those of us residing in the United States. So that trial is in motion. My program here at Mayo Clinic is not an enrolling site yet. I'm looking forward to hopefully hearing from them to see if they want our participation for that. The other, as you heard me mention, is Solid Biosciences gene therapy trial for patients with CPVT from ryanodine receptor mutations. That trial is in design and it's being advanced. No enrollment date has been announced yet. And so if I had to put a guess out, I would be guessing late 2025 or early 2026. Dana from Ireland. We were just talking about Ireland. The other day, Rory McIlroy. How awesome is that? The Masters champion and the career Grand Slam. I think that was amazing. And his caddy, lifelong friends. Wasn't that incredible? Anyway, LQT dancing at the World Championship. Oh, sweet. I thought there was a question, but that's awesome. Back there is one of my long QT patients who was a U.S. dance champion. Amy, are there or will there be a study on nursing moms on mexiletine with type 3 long QT syndrome? I guess the question is there concerns about mexiletine in the breast milk for a lactating mother and the impact on their babies? I don't know. I'm not aware of any study. I'm not designing one to that effect. I do not change in my practice for my patients. I do not discourage breastfeeding at all. Never. I've been taught that. And clearly, the expression breast is best is a well-founded one, scientifically, emotionally, and so forth. Now, so my patients with long QT3, if she, as the mom, wants to breastfeed her baby, absolutely, all for it, will support it. And I'm not concerned about the use of the beta blocker in breast milk, the use of mexiletine in the breast milk on the developing baby. But I'm not aware of a study that's in motion to try to add any additional scientific data to the question. Megan my husband was diagnosed with congenital LQT2 after genetic testing, never a symptom. Now he's 53, so young. He's part of my club. Remember that club, the 50s club. We invite people into that one. And I'm still in it. And his recent EKG did show the notch T wave, which you've read to be distinctive of LQT2. However, his QT number was in the normal range. I assume he should still have a full workup to determine his risk level. Great question. My view is that, and again, remember, I am never giving direct personal medical advice. I'd have to be looking at your information. And when I do that, spending probably 60 to 90 minutes with you. So again, that's that reminder that I try to use your incredible questions to get at the issues that are relevant. I'll tell you in my program, I think every patient with a positive genetic test result must undergo at least one comprehensive evaluation, no matter what their age, to determine what is the level of electrocardiographic or phenotypic expressivity of their LQT2 mutation, LQT1 mutation, RYR2 mutation. Doesn't matter. Every variant positive genetic test person must be evaluated. Now, after that evaluation, if I conclude that it's non-penetrant or as close to non-penetrance as we can declare, then I will explore with them the idea of intentional non-therapy or INT. And in the case of long QT, we would keep the QT precautionary preventative measures in place. So we dial in therapy ranging from no therapy but prevention measures all the way to defibrillator therapy or beyond to a transplant, for example, depending on what does the owner of that mutation, what is he or she showing with the various cardiac tests. Then based upon that initial evaluation, I decide whether I need to do that cardiac health check yearly, every 6 months, every 5 years. And that answer depends on the situation in each person. So I would say, of course, that kind of person, a person like your husband with that profile, needs to be evaluated. Now, the Notch T-wave look that is mentioned is not a risk factor. It's a look that gives us a hint as to where in the genetic code did the mistake occur, LQT2 as the answer, but it's more the length of repolarization, the QTC number on that morning ECG that helps us decide whether it's looking like ultra low, low, medium, high, spicy in terms of risk. Love the question, Megan. Katie, son and I both have LQT8, strong family history of sudden death in their 40s. Never like seeing that. Your son is asymptomatic. That's great. You have a defibrillator. Due to family history, should we you have a defibrillator. Due to family history, should we be prepared to get one for your son? Oh, I love the question. And the reason I love the question is there are certain SADS conditions, and the best one where the evidence is strongest is hypertrophic cardiomyopathy. Now, most of my patients and families and those throughout the United States, their home for advocacy and support is the HCMA, Hypertrophic Cardiomyopathy Association, led by Lisa Salzberg, a dear friend. Now, the reason I mentioned that genetic heart condition is we know for that condition that the family story is a risk factor, meaning if there's a history of tragedy, that's not just sad for the family, that's a direct risk factor for the other owners of that disease who are immediately connected to the one who died. Now, in long QT syndrome, that is not true. I'll say it again. In long QT syndrome, that is not true. The family history, tragic for your family with 2 deaths or deaths in the 40s, does not have risk forecast value for your son or for you. So every owner of a long QT mutation, I evaluate on what's their profile, and I largely put blinders on as to the family expression in other owners of it. I take note of it. I know that it's emotional as a risk factor if there's been a death of 1, 2, many individuals. But whether that story is awful or benign, that doesn't influence my assessment of the person in front of me who's the current owner of that family mutation. So I hope that helps frame, because it's an incredibly important question, and I'm glad Katie asked it. Oh, that's an awesome name. I don't think I'll be able to say it right. I'm going to try though. Malgorzata. he or she is telling me that the QTC number is 490 to 515 and doesn't have a mutation. I also don't take any medications that could prolong it. I'm not sure what the question is there, but in general, remember that number importantly needs to be vetted. Is it correct? Has it been measured correctly, or is it wrong? I have a lot of patients who've been labeled with long QT syndrome for a lot of years, and that label gets undone after their second opinion evaluation. So in my program, if somebody is said to have long QT syndrome and they are mutationless, meaning their long QT genetic test is negative, could they still have long QT syndrome? Sure. And then in that case, we would call it genotype negative long QT syndrome. And there are still new genes to be discovered. But when we know that the current generation genetic test, if the diagnosis is truly correct, should give us the mutation 80 to perhaps 90% of the time, maybe higher, then if that test comes back negative, then that family deserves a careful reassessment to determine whether the diagnosis is correct in the first place. If correct, then we proceed to think about novel genetic testing strategies in the research mode to find the new gene or the new cause. But many individuals with apparent genotype negative long QT syndrome don't actually have long QT syndrome. So a negative genetic test for that disease mandates a careful reevaluation. Now, a negative genetic test for a different SADS condition, Brugada syndrome, doesn't mandate a reevaluation because the current genetic test is only positive 20% of the time in people who really have Brugada syndrome. I hope that makes sense. And I love it. I took the liberty to predict what the question might be without seeing it. Shannon, oh, wow, we're on fire today with lots of them. I better pick up the pace with pithier answers to your nice, short, tight questions. But Shannon, I have congenital long QT. Oh, and your mom died 9 years ago. I'm so sorry of that. The cause of death was cardiomyopathy, not long QT. My immediate family won't get tested. Is it possible to know that my mother had long QT? In cases where there's been someone who's died, the only way to know that they might have had long QT is if there was by chance an ECG that was obtained during that person's life where the QT number was missed or not commented upon. But if there's no ECG, the only way to know that somebody who died suddenly would be to do what we call a molecular autopsy. And that is to sequence the genetic code of the deceased individual to determine whether there were any long QT mutations there. Brennan, and this is again from 2 now in a row from our Instagram platform and those joining us from that platform. How rare is WPW, Wolff-Parkinson-White syndrome, and how successful is surgery just diagnosed in March? Well, I appreciate the question. We don't hear very much of that one. And I'm glad you could join SADS and feel like you're getting answers met. WPW or Wolff-Parkinson-White syndrome is not really genetic, almost never. There's a couple of entities where that electrical feature called the delta wave or pre-excitation might be part of a genetic syndrome. But for the most part, it's one of the more common non-genetic heart rhythm issues. The exact number of how common or rare is it, I'm not sure that I know that answer off the top of my head. It's for sure more common than long QT syndrome, which is 1 in 2,000 people. And it might be on the same ballpark as hypertrophic cardiomyopathy. And I'll throw out a number, I'm probably wrong, but on the order of 1 in 500 individuals. Now, those who need ablation for their WPW pathway, Depending on where that pathway is located in the heart, the success rate varies, but overall, the success rate is extremely high, as in north of 90%, 95% success rate. Rhonda, again, 3 in a row Instagram. So my son, oh, golly, her son died suddenly and they think he had long QT. How do we know? Well, I'm so sorry for your son and for your family. What often happens is if somebody dies suddenly at a young age and the autopsy is completely normal by eye and by microscope, then the medical examiner community or the pathologist, they wonder out loud whether it could be long QT to blame. And I love that they're thinking that, but unfortunately, that is causing out there a misperception that if somebody dies suddenly and the heart structure looks normal, it is long QT syndrome. And that's just not correct. In fact, most of the time, it won't be. So if they're thinking that, then we have to figure out why are they thinking it? Are they thinking that just because they found nothing on the autopsy? Okay. Well, that's a reasonable thought, but you need to start mounting evidence. Should the family members surrounding that deceased individual get evaluated? Yeah, absolutely. So in the case of this tragedy, that individual's siblings and that individual's parents and that deceased individual's own children all need to have at least one very thorough cardiac evaluation to see if their heart is structurally and electrically normal. If a molecular autopsy cannot be performed, or if it is performed, but nothing is found. Jacqueline's daughter has ARVC, persistently high troponin levels, normal things otherwise. Have you seen this before? Any idea why troponin would be elevated? Oh, wow, these are incredible questions today. So it depends. So troponin is what's called a biomarker that when it's elevated, it suggests that there's injury or inflammation of the heart muscle cells. And so the real answer depends on what are the troponin levels? Is that person's ARVC mutation known? Because there are some ARVC subtypes that give more troponin leak than others. For example, DSP or desmoplakin ARVC is more often associated with higher baseline troponin levels. If the person is not having any symptoms of concern, my approach is I just follow those troponin levels as part of their annual evaluation or periodic evaluation. If, on the other hand, there are arrhythmias or changes in imaging, then that might be telling us that the patient's in the midst of what one would call a desmosomal flare, where there might be acute or transient active inflammation going on. Such a good question. Never been asked before in the history of SADS Live. So Rachel's saying, so I'm saying that you're having long QT syndrome does not mean my children, grandchildren do not have to worry about having it. No, what I would be saying in general is if a person, let's say you in this case, has long QT syndrome, and if it's genetically known, then each child that person creates has a 50-50 chance of passing it on to each child. If the answer was yes, it was passed on, then that child needs to be carefully evaluated. Now, I don't remember if, Rachel, if you were a preceding one, but if a person has what appears to be gene negative long QT syndrome, that doesn't mean that the family is off the hook. That just means we don't have the luxury of having a genetic test marker to tell us yes or no, yes or no. And so in my very few families who I have called them gene negative long QT syndrome, I have to keep their children under some surveillance because I don't have a genetic test marker that allows me to dismiss them because they tested negative for it. Anne Marie, why are we seeing more genetic, less asymptomatic Brugada related SCA events, especially in women in their 30s? Good question. Great question. I'm not sure we are seeing more. So I don't know that we have any data to suggest that there's been an epidemiological increase of women with Brugada syndrome who've never had a symptom, then go on to have sudden cardiac arrest. What we do know is that the majority of men and women diagnosed with Brugada syndrome do genetic test result. Remember, I shared that overall, if I take all patients diagnosed with Brugada syndrome, the positive genetic test rate of the unrelated individuals designated diagnosed with Brugada syndrome is 20%. It turns out that if they show Brugada pattern and a prolonged PR interval, then the yield of the genetic test is actually 40%. Whereas if they have Brugada syndrome ECG pattern, but a normal PR interval, and I order the same genetic test, the yield of that genetic test is actually 10% or less. So you can really have Brugada syndrome, and you will usually have a negative genetic test. That just means that's how we care for you without being able to then use that result to figure out who else do I need to care for or evaluate in the family. So we know that in the largest studies published, a beautiful study, I forget the name, the header name of it, but it looked at an incredibly large number of patients with Brugada, men and women. And if you were asymptomatic and you had low risk features, your annual rate of a Brugada triggered cardiac arrest was less than a 1% chance per year. So I've seen no data to suggest that that rate has changed or is increasing at all. Val is asking, but great question, I love it, but we have to always make sure that we don't grab onto a headline or noise and think that that is necessarily factually based. Val is asking if there's any new updates on gene therapy for type 1 long QT syndrome. The short answer is no. We published a year ago now the therapeutic efficacy trial of LQT1, our LQT1 gene therapy in rabbits. Very effective signal. Our program and our suprep gene therapy for LQT1 has now been licensed by the company Solid Biosciences. They have licensed 6 of our different disease gene therapies, and we're co-developing them. LQT1 is still a priority of mine, but we are focusing energy for the first effort to see if we can get the gene therapy for LQT2 across the finish line. Why? Because the powers that be have declared that there is much more unmet therapeutic need in LQT2, which is true, than in LQT1. While I agree with that, it makes sense that we're doing it this way, but I am not giving up on LQT1 gene therapy at all. It's just that right now, we cannot advance a gene therapy for LQT1 when the number one reason for its advancement is I hate my beta blocker. I believe we're going to get there, But when you think about all of the impediments to gene therapy and to FDA approvals and the regulatory hurdles, it is wiser of us to see if we can get there by proving that it works for LQT2, because there is more breakthroughs on current therapy in LQT2. And then ultimately, if we have success, bring LQT1 second in line, as the regulators will be more comfortable with quality of life reasons for a gene therapy, rather than the only reason being the unmet need. I can explain that more later, and if it ever becomes necessary. But that is the economic, tactical reality of our program. Now we're working on new drugs for LQT 1, 2, and 3, and there the energy barrier, if you will, is lower or easier to overcome than when you're trying to advance gene therapies. I love your question, Val, and I hope I gave you a solid answer. Would it be possible, from Andrea, to live efficiently with both a cochlear implant and an internal defibrillator? Oh, absolutely. So I have patients who, now usually, remember, for our SADS families, all of our patients with LQT 1, 2, and 3, they basically never have deafness. If they do have deafness, they have deafness for a different reason than their LQT 1, 2, or 3. But the small number of very special long QT families who have autosomal recessive 2 mutations in the LQT1 gene now have the disease called Jervell and Lang-Nielsen syndrome, JLNS. And as a consequence of having 2 mutations in that potassium channel gene, where that potassium channel resides in the endolymph of the inner ear, those individuals have bad LQT1, or worse LQT1 in general, and congenital deafness. And so many of them need cochlear implants, and some of them may also need an implantable defibrillator, depending on the severity of the cardiac expression. And when my patients need both, we do both, and they can absolutely live and thrive with both. So no problems there. 7 minutes on our counter. Tara, daughter has LQT1, diagnosed with the genetic testing after a faint, started on the beta blocker Nadolol about 7 months ago. She's 8, seems to be struggling with anxiety, and I'm sorry to hear that. There's no history of it. I'm curious if this could be due to the Nadolol and whether we should be exploring a different beta blocker. Great question. Not easy to separate, but there's no doubt in my mind that for some individuals, the beta blocker, no matter what its name, Nadolol, propranolol, carvedilol, does not agree with them in terms of their mental well-being. I've seen it plenty of times. Is it guaranteed? No way. Do many of my patients tolerate their beta blocker with no negative impact on their well-being? Yeah, absolutely. So I don't want people thinking that beta blockers are terrible. That I think that has emerged somewhat as a misleading message. In my world, I get that enriched view of patients who are dissatisfied with quality of life on beta blocker, because they then come to see me seeking beta blocker alternatives. And that creates a view or an impression that, oh my goodness, everybody's a beta blocker zombie out there, or beta blockers are awful. Not correct at all. I would bet that even in my program, where there's an enrichment to come for an alternative therapy, the beta blocker strategy that we're on is all we need, and they are, most importantly, satisfied and pleased. The majority, 65%. But there's a solid minority where the therapy has caused problems. The two most common reasons in my program why we explore different treatment strategies from their beta blocker is either beta blocker fatigue, the zombie, as they call themselves, or beta blocker mood change. That tends to be a blotting of the mood or sort of, I don't know, behavioral outbursts as the description. What I always tell my families of children is that they know their child the best. They know their child before the therapy was started. They know their child after the therapy. And if they're concluding that there's something that has changed and there's no real change going on in that family unit's life stressors, situation, and so forth, that yes, we need to bring that to the attention of your cardiologist to explore options. Just did that this week with a family where we have chosen for that particular family to do a beta blocker holiday, to retreat off of the medicine, to then reassess, do all of those symptoms that seem to have started, do they disappear? So we can try to convince ourselves that it's truly true and related. Now I'm not advising that for sure for yours, because I would need to know what is that person's risk of their long QT. Do I think we have room to do that exercise to explore? If I think it's related and the family thinks it's related, we do have options. And one option, for example, is to shift to a different beta blocker. In the case of Nadolol, which you're on, which I like a lot, shift to another beta blocker that I like a lot in terms of being very confident in its efficacy, and that's propranolol. But often, if they're not liking one beta blocker, that pattern remains. And so then we will explore for individuals, especially individuals with LQT1, whether we can shift to a beta blocker alternative like the one-time surgery called videoscopic left cardiac sympathetic denervation, which may enable us to, for sure, lower the dose of their beta blocker and potentially remove it altogether and have them on just one-time therapy. A lot of decisions involved in that one. But the most common reason for our denervation surgery program now in 2025 is I am not pleased with my quality of life on beta blocker. We've got to do something different, rather than my disease has been super dangerous. It just reared its head again on the current treatment. We need to add more. And so there's been a shift in that. Well, that is an incredible question. And I must say, I love our Q&A time. Your questions are just so riveting, stimulating, and thought-provoking. So I thank you for taking the time to pen them. And we are going to pick up the next Q&A session with Beth's question. And so we'll start with that one as the next one. And it looks like I missed 1, 2, 3, 4. Oh my. I thought I was going, but I missed 4 of them. So we will start with those remaining 4 the next time we get to be together. And so until that next time, I wish you all well. For those who are celebrating one of the most incredible weekends of the year for Christians, Easter weekend, Good Friday today, and the Blessed Resurrection on Easter Sunday, I wish you and extend to you Easter blessings. And for all of you, be well. Thank you for being part of SADS Live and SADS Nation. And I can't wait to be with you again. Bye for now.